This is kind of part 2 on the hunt itself, related to types of dissociation that are different from what we might usually expect. In this context, when they say a negative symptom, it means a symptom that takes away from, and when they say positive, they means adds to. In the last video, it went over negative psychoform dissociative symptoms, which is more like mental or psychological negative symptoms. In this one, we are starting out with negative somatoform dissociative symptoms, which is more like negative symptoms in the body. Original 19th and early 20th century clinical sources strongly suggest that structural dissociation also manifests in physical symptoms and functions. Modern empirical evidence supports this. Negative somatoform dissociative symptoms occur in survivors as ANP, but may also be seen in EPs fixated in freeze or in total submission. They include symptoms of loss of motor functions, including motor skills, and sensations that should normally be present or available. Loss of motor function. Temporary or more permanent loss of motor control includes partial or total paralysis of limbs or the entire body, contracture, physical lack of coordination, cataplexy, for example, a sudden and general loss of muscle tension, in loss of hearing, smell, taste, vision, or speech. These symptoms are often dissociative in nature and can be trauma-related. For example, dissociative contractures were frequently observed in traumatized World War I combat soldiers. Loss of motor function and sensation also occurs in survivors as EP that are fixated in freeze or in total submission. With regard to freezing, patients report being unable to move while still feeling extremely fearful and hypervigilant. This freeze condition should be distinguished from total submission, in which patients find themselves in a condition of extreme shutdown and disengaged from the environment, feeling nothing emotionally or physical, and lacking any drive to move or think. In this condition, survivors' muscles become flaccid, and sometimes they temporarily may remain in fixed positions. The somatoform dissociative symptom cluster that includes bodily anesthesia, analgesia, and motor inhibitions predicted the presence of complex dissociative disorders extremely well, better than any other somatoform dissociative symptom cluster. Loss of skills. Loss of skills not only involves the absence of certain mental actions, but also behavioral actions. When EP has complete executive control, the daily life skills of ANP are often missing. Thus, survivors as EP commonly report that they have no idea how to cook, take care of children, or perform work duties, and generally feel inadequate and overwhelmed with the tasks of daily life because they do not have access to needed skills for periods of time. Loss of sensation. The loss of sensation is a common occurrence in traumatized individuals. Varying degrees of anesthesia may occur. More or less profound loss of bodily feelings may include sense of touch, pressure, temperature, pain, movement, arousal, including sexual arousal, and other physical signals such as hunger or fatigue. These losses may induce certain symptoms of depersonalization, such as experiencing parts of the body as a foreign object. Other manifestations of the loss of sensation include partial or complete loss of hearing, vision, such as tunnel vision, taste, and smell. Positive psychoform dissociative symptoms. Whereas negative dissociative symptoms involve experiencing and knowing too little, positive psychoform dissociative symptoms are manifestations of experiencing and knowing too much. Positive symptoms include the intrusion of symptoms of PTSD and other trauma-related disorders. They typically present intrusions of EP into ANP, as well as full alternations among ANP and EP. For example, when survivors as EP are fixated in a particular traumatic memory, this part may intrude into ANP. Survivors as ANP then may experience the same memories and emotions as the EP, but without clear understanding of what they are. Schneiderian symptoms, I'm sure I'm pronouncing that wrong. Mental intrusions of one dissociative part into another part are often interpreted by clinicians as evidence of many of the 11 Schneiderian first-rank symptoms of schizophrenia. They include hallucinations, such as voices arguing or commenting, and images of traumatic experiences, thought insertion and thought withdrawal, and delusional thinking. Other Schneiderian symptoms are better categorized as positive somatoform dissociative symptoms, as described below. Schneiderian symptoms are usually experienced as ego-dystonic and as emanating from inside rather than outside. Dissociative voices can generally carry on a conversation with the therapist and with other parts of the patient, while the voices of schizophrenia have a rather fixed and repetitious pattern and cannot be engaged relationally. In relatively simple cases of structural dissociation, voices may only be limited to something that occurred during the traumatizing event. For example, the sound of a baby crying, or the voice of a child saying, "Please don't hurt me anymore," or the voice of a perpetrator saying awful things. As the complexity of structural dissociation increases, and as various parts of the personality develop more relationships among themselves, the quality of the voices may change to include topics in the present. For example, an EP may have a running commentary on the actions of ANP, such as, "Why can't you ever do anything right?" Or various EPs may talk with each other, resulting in a sense of chaotic background chatter for the AMP that can be quite distracting. Or certain parts may interfere with work by saying things like, "This is so boring," and some AMPs may be helpful. "Come on, you can do it." A common experience of dissociative patients is the sense that the thoughts have been put in or pulled out of their mind, thought insertion and withdrawal. Generally, this is an experience of part of the personality in executive control at the time, for example, an AMP, while the insertion or withdrawal is controlled by another part. Delusional thinking may occur in dissociative individuals, but more often the actual difficulty is other types of disturbed cognitions related to dissociation. Cognitive appraisals. Dissociative parts may have quite different worldviews, senses of self, and systems of belief. Thus, there may be confusing alterations between very discrepant cognitive appraisals and perceptions of people and situations in self. Fantasies and daydreams. Fantasy proneness involves a lack of critical function, which could be considered a negative dissociative symptom when it pertains to one or some dissociative parts but not to others. The presence of fantasy may sometimes constitute a positive symptom. For example, an AMP may fantasize about a happy childhood even though the contrary was true. Alterations in relations with others. Dissociative symptoms may appear in survivors in the context of interpersonal relationships. For example, as ANP, a survivor may feel connected with and think highly of a close individual and treat that person well. However, an EP may feel very threatened by closeness with the same person and treat him or her with suspicion and hostility. When such ANPs and EPs intrude into and alternate with each other, traumatized individuals may exhibit a disorganized attachment style. Alterations in affect. Mood swings and affect dysregulation are common in complex PTSD. These alterations may relate to structural dissociation. For example, affect that is generally not present in the survivor as ANP may suddenly and unexpectedly intrude into daily life from an EP with such vehement emotions related to traumatizations are re-experienced. Positive somatoform dissociative symptoms. Positive somatoform dissociative symptoms involve specific sensations, other perceptions, and motor or behavioral actions of various dissociative parts of the personality that do not occur in other parts. These include pain, intentional behavior, repetitive, uncontrolled movements such as tics, tremors, and palsy, and sensory perceptions, including vision, touch, hearing, taste, and smell, that may or may not be distorted. Re-victimization is a positive dissociative symptom when dissociative parts of the personality fixated in total submission are reactivated and take full control of consciousness and behavior. Schneiderian symptoms. Positive somatoform dissociative symptoms include symptoms of somatic passivity, such as the sense that the body is being controlled by somebody else, and that impulses and actions intrude on one dissociative part of the personality from other parts. Intrusions of traumatic memories generally have a sensory component. For example, individuals may have a sensation of a hand around their neck, or of their hands tied, or of someone sneaking up behind them. Some visual disturbances involve an aspect of re-experiencing, such as seeing the perpetrator's face superimposed on a therapist's face and seeing specific images of traumatic experiences. Other perceptual alterations may also be positive somatoform dissociative symptoms, including sensory hallucinations related to traumatic experiences, such as the smell of alcohol, interplay between parts, and field of consciousness. I have 3 parts left from this chapter that I'm going to put in this video. They include the interplay between dissociative symptoms and what field of consciousness is and what level of consciousness is and kind of what the differences are between those two. The interplay between various dissociative symptoms. While we have distinguished negative and positive and somatoform and psychoform symptoms for purposes of clarity, in practice, many symptoms involve all of these forms of dissociation. Positive and negative symptoms may alternate with each other or may simultaneously coexist. Thus, alterations in affect may involve positive symptoms in one part of the personality, presence of a strong affect, while other parts exhibit negative symptoms, a loss of affect. And since affect is related to behavior, dissociated affect may well involve somatoform dissociative symptoms. For instance, a dissociative part of the personality who is rageful may hit a wall, which is a positive somatoform symptom. Another dissociative part does not feel the rage, which is a negative psychoform symptom, and says, "I did not hit the wall and my arm feels numb," which is a negative somatoform symptom. The enduring nature of negative symptoms is commonly related to the usual executive control of the survivor as ANP, which has only sporadic intrusions of EP. However, positive symptoms may sometimes become more persistent in daily life. When this happens, ANPs become less functional and EPs become intrusive more frequently. Also, during the course of therapy, as more safety in the present is experienced by all parts of the personality, there may be increased intrusions as more EPs begin to engage with the therapist. New passage. We return to Genet's 1907 definition of hysteria, which was the old term for generic dissociative disorders, to better clarify the difference between structural dissociation and alterations in consciousness. The field of consciousness. The quantity of stimuli that are held in conscious awareness at a given time is referred to as the field of consciousness. This field can range from very wide to extremely narrow or retracted, so that an individual can be aware of a lot in a given moment or very little. Not all perceived information will be available for recall because it is impossible and quite maladaptive to remember every perceived stimulus. Yet sometimes we are able to take in more than others, depending on the width of our field of consciousness. Sometimes this is a voluntary process, as in the form of intentional concentration, guided imagery, or meditation. Other times it is not within our control, and may take forms of inability to concentrate or focus when we are stressed, an excessive fantasy life, staring at the wall for hours, unaware of the passage of time. Retraction in the field of consciousness, or narrowing of attention, is characteristic of both ANP and EP. However, even though retraction and other alterations in consciousness may accompany structural dissociation and integrative failure, they can also occur apart from structural dissociation. The point is that underlying mental actions are fundamentally different from structural dissociation. In structural dissociation, dissociative parts recall at least some experiences and facts, creating episodic and semantic memories that may or may not be accessible to other dissociative parts. Alterations in consciousness generally involve a failure to create such episodic and semantic memories in any part of the personality. Level of consciousness. Alterations of the level of consciousness range from very high to very low levels. A high level may portend to hyper-alertness, such as when an individual or a part of the personality is intensely searching for threat cues. Lowering the level of consciousness denotes impaired quality of mental and behavioral action, a failure to adequately perceive and remember experiences and facts of importance, no matter how wide or narrow the field of consciousness. Lowering of consciousness can manifest in common phenomena such as concentration problems due to fatigue, anxiety, or illness, as well as symptoms of depersonalization, such as feeling unreal, spacey, foggy, detached or strange, derealization, and time distortion. The field and level of consciousness work in tandem at all times. Focused attention involves a combination of voluntary retraction with a high level of consciousness. Mindfulness can involve a wide or narrow field and a high level. Low levels of consciousness, along with wide or narrow field of consciousness, result in conditions of spaciness or drowsiness, trance, or unresponsiveness. Normal versus pathological alterations in consciousness. Narrowing and lowering of consciousness have typically been described in the literature as normal dissociation or non-pathological dissociation, mild dissociation, or minor dissociation. However, these alterations do not need to involve structural dissociation, thus belong to a different category. Both high and low levels of consciousness can be quite pathological when they are excessive, frequent, rigid, and inflexible. For example, during threat, a high level of conscious awareness and retraction of the field of consciousness to threat cues are adaptive, when exclusive focus on perceived danger occurs in everyday life when no threats exist. On the other hand, if a person is not able to achieve a highly focused field of consciousness during threat, such as in a state of total submission, then potential ways out of the situation may not be noticed. Normal attention waxes and wanes over the day. Periods of high alertness may be punctuated by periods of drowsiness or fatigue. It is adaptive to intentionally enter trance states for healthy relaxation, whereas spaciness is generally maladaptive, though it often occurs when one is tired, sick, or stressed. But a more serious lowering of consciousness, in the sense of being in a kind of trance or in another world, is a common experience in adult survivors of childhood abuse and neglect. The failure of people to recall experiences and facts in any part of their personality under conditions of abuse and neglect has been described as dissociation of context or dissociative detachment. That's it for Chapter 5.